prompt some more questions. So this is just some basics about transthoracic echocardiogram, including images, so that when you order these studies and see the feedback, you can be, understand a little bit about what we see, what we can't see. So this is what I carried around as a fellow. You can tell by the stain on the paper, but it highlights the viewing windows that you use when you do a transthoracic echocardiogram. So left parasternal there, apical. So in other words, your probe will be here, and then you'll adjust the rotation, alignment, and angle of it in order to obtain the images. Apical, subcostal. Subcostal is great for things, for example, like the IVC, and we'll see, all of these images and where they're taken from. Right parasternal and apical are less used, but can be. And the suprasternal is very important, for example, interrogating the aortic valve to ensure that there's not or is severe aortic stenosis related to the change in angle of the valve with age. So here you go. These are basically different viewing angles in what you're going to see, and we'll go through kind of all of these, but the slide's available for reference and hopefully a useful anatomic correlate to what we're seeing here. So, okay, so this is where we typically start. It's a parasternal long axis view of the left ventricle. And so these are the structures. The right ventricular outflow tract is on the top. This is a dilated right ventricular outflow tract. Normally it won't be so big, and there's a reason for that. It maybe correlates with this talk. The aortic valve AOV is there moving behind. The left ventricle is, of course, the largest squeezing muscle, so you can tell by the mass that that's that chamber. The left atrium is there, and between the left atrium and ventricle is the mitral valve. And so there's the parasternal long axis view. This is going back to that card. Again, the anatomical structures: right ventricular outflow tract, left ventricle, left atrium, aorta, and the valves between the chambers, as discussed. So here's sort of another view of where you would, anatomical view that you might see in Netter or some book like that, where you see the plane that you're cutting through. Look at that. When you do the parasternal long axis view, and that gives some additional detail as far as the scallops of the mitral valve and cusps of the aortic valve that are mostly germane to us cardiologists trying to localize certain structures or endocarditis and things of that nature. And then once we have these views, we just zoom in by structure, zoom in on the mitral valve. Is there a little bit of regurgitation? And you can see that, backwards, that there is some trace regurgitation of the mitral valve there, that little blue flow going backwards into the left atrium right there. We do the same thing for the aortic valve and look at color flow dynamics and a lot of Doppler physics to tell us about how those valves open and close and the extent of regurgitation and things of that nature. And then we'll often, especially in the parasternal, use M mode, which gives us excellent temporal resolution. So you have this little line. That seems to advance the slides every time I touch it.
Go ahead.
Okay, so you have that little line that will go through sort of like a pick through that part of the heart. And in this case, you're seeing the mitral valve opening and closing, and such as that way. So as you go down this line, you will enter different anatomical structures, such as the intraventricular septum and the posterior wall, and so on and so forth. Okay. And so now here's the tricuspid valve. So here, instead of yeah, that's good. You can leave it there, I suppose. What you do is just rotate from the parasternal long axis of the left ventricle towards the right ventricle, and then you'll see the tricuspid valve, the right atrium, and right ventricle as demonstrated there. So there's some, if you were actually taking these images yourself, there's some tips for how you would do that. You would angle medially and rotate slightly clockwise to go from the parasternal view of the left ventricle to the right ventricular inflow view. And so again, we add some color flow. In this case, there's moderate, almost severe tricuspid regurgitation. So this is a dilated right ventricle. And some functional, that means the tricuspid tips are not coapting well, leading to tricuspid regurgitation. Now, this is the short axis view of the left ventricle. This is about at the line of the papillary muscles. And so if you can move over to the laser again. There we go. So here are the papillary muscles here. The left ventricle, of course, is here. And again, in this echocardiogram, the right ventricle is dilated, and there's some D-shaping of that interventricular septum telling you that the pressure is high in the right ventricle. So this is kind of going along with the idea of diastolic dysfunction causing pulmonary hypertension. This D-shaped right ventricle would be seen in somebody with pulmonary arterial hypertension, which could be from chronic venous pulmonary hypertension, but more likely primary. So there you go, parasternal short axis view. Left ventricle, interventricular septum, and right ventricle. Different view of the same. Okay, and then you kind of will go up and down the left ventricle at various segments, more apically and towards the apex and back towards the base to see the wall motion in various segments of that chamber. Same thing. Here's at the level of the mitral valve. Here's the mitral valve opening up like a fish mouth on Foss with the left ventricle. I'm needy today. Left ventricle down here, right ventricle here, and the fish mouth opening of the mitral valve there. So same thing, going, this is the parasternal short axis at the level of the base where the mitral valve is. And then if you go up even farther, what you'll end up with is the aortic valve, and I've labeled the cusps, right non-coronary cusp and the left coronary cusp. The non-coronary cusp correlates with the intra-atrial septum, which is mostly something that we teach fellows in cardiology fellowship. Left atrium is labeled, as you see. Right atrium, tricuspid valve, again the right ventricular outflow tract, pulmonic valve, and the pulmonary artery. So there are those structures. And that's, again, just a little superiorly or more basal to the mitral valve. So you just kind of go up and around and you get more structures. There's another view of the same thing in a cartoon format. And then you have an apical four-chamber view. And as you see, it's labeled left ventricle, left atrium, right ventricle, right atrium. There we go. Same idea with those flashcards. And then again, you just put some Doppler flow on various valves, and you can see if those valves are regurgitant. There are some ways that you can tell, apart from just the leaflet opening, whether those valves are stenotic as well. But mostly we use Doppler flow hemodynamics to distinguish, especially a stenotic aortic valve, but also other valvular stenoses. We'll look at the gradients. Okay, so there you go. So this is a so-called five-chamber view. So the four, So the 4 chambers, left atrium, ventricle, right atrium, and then the aorta is considered the 5th chamber in that view. So, or left ventricular outflow tract view. And then you switch over to the apical views, as we have with the 4-chamber, and rotate your probe to look at a different angle and different territorial distributions of the myocardium. For example, in the left ventricle, so here's the left ventricle. Oh, there we go. Left ventricle, mitral valve, left atrium, aortic valve, and the ascending aorta. And so the idea is that whereas before you might have been looking at the septal and lateral walls, here you're looking at the septal and inferior basal walls. So there's a cartoon view of the same. And then you come subcostal and look at a 4-chamber view that way. So you'll have left ventricle, left atrium, right ventricle, right atrium, and the subcostal view. That's looking, you're going to have the patient draw their knees up to their chest and push the probe subxiphoid in order to get that angle appropriately. So you'll be imaging from the belly, and there's a cartoon view of the same. And as you do, you can sort of scan superiorly and find where the inferior vena cava basically goes into the right atrium. And the size of that is used to estimate the right atrial pressure. Normal size is less than 2. Some people will put the upper limit of normal of IVC size up to 2.2 centimeters. So this IVC measured at 3.18 centimeters is well dilated. And so the dilation and ability of that to close more than 50% with sniffing tells you the other part of how high the right atrial pressure are. So you just look at how big it is and if it closes when they sniff in, and that tells you about right atrial pressure. And so then this is a curious case because there's a dilated coronary sinus, which, there we go. Shouldn't just leave it there. A dilated coronary sinus, which can happen with certain embryologic abnormalities, such as a persistent left superior vena cava or elevated pulmonary pressures, which was the case in this situation. And then the descending aorta is outside of the pericardial reflection, and that's how you tell that. And so this person actually ended up having a persistent left superior vena cava, which only affects pacemaker implantation and a few other things. But so let me go in, before we talk about questions, to some diastolic function parameters. And again, as we were talking about earlier, myocyte relaxation is the energy dependent step. And so what we're measuring with diastolic function is how much force it takes to get blood into the left ventricle. And usually that should be a very compliant chamber, but not always. So I'll preempt just a little bit by showing you some hemodynamics, and this is a bit complicated, but this is the left ventricle during diastole. That's the left ventricular pressure. This is the left atrial pressure during diastole. And if you put them together, the change in pressures, so that a gradient between the left ventricle and the left atrium, such that there's blood flowing into the left ventricle, occurs in 2 phases. An early phase, which is left ventricular relaxation, and then later, actually later in diastole, the atrium will squeeze and force blood into that left ventricle. So there's an early phase of diastolic filling and a later atrial contraction phase of diastolic filling. So there you go. Early phase, E wave is the early filling and A wave is the late filling. So here's the E wave, there's the A wave, and you can visualize that actually just if you do some high fidelity imaging via M mode of the mitral valve, you can actually see that happening in real time. Alternatively, you can put a Doppler probe across the tip of the mitral valve leaflets, and you can measure the velocity of early filling and atrial contraction. And this is the predominant way that we would define diastolic function 5 years ago. And so the relative velocities of the E and the A wave tell us about diastolic filling. So with diastolic dysfunction in grade 1, you'll get a muted E wave and a higher A wave, so-called E to A reversal. What we've since learned is that the E to A ratio, as you see it there, is affected by how much volume overload you have at the time this study is done. So people may be relatively diuresed, they may be relatively volume overloaded when they get their echocardiogram, and on the basis of that, they may have a normal E to A wave or an abnormal E to A wave based on how much extra fluid they have in their body at that time, or lack thereof. And additionally, E and A are highly variable with either younger athletic types or older people. And by that I mean, in the 70s and 80s, there's a much greater variability of normals, people who have no evidence of heart failure with regard to their E to A velocities relative to each other. What is the alternative means of measuring diastolic dysfunction is to look at a tissue Doppler of the left ventricle. So as the left ventricle opens and relaxes, that will cause an E prime, which is the relaxation of the left ventricle during early filling, and an A prime during late filling. So there's a tremendous amount of ways to measure diastolic filling. You can look at what I was showing you, mitral inflow, E to A, and there are phases of diastolic function. Now we have excluded stage 4 and mostly graded 1 through 3, but then there's you can use the valve, you can have them Valsalva, that will change their E to A wave unless they have a restrictive physiology. You can look at pulmonary vein flow and tissue Dopplers, all these things. So it's very complicated, I'll say. And what we've done now is distilled it down into those 4 things that we said, which are the E prime velocity, the tricuspid regurgitant velocity, the left atrial volume, and then you can take the ratio of that E wave that I showed you to the E prime, and that will tell you about acute volume overload. So if 2 of those 4 are there, then they have diastolic dysfunction. If they're not, then they don't. So I will just summarize to say that the measurement of diastolic dysfunction is controversial and complicated. We probably have been overdiagnosing it for some time. And the reason why we've cut back and called much less diastolic dysfunction by our guidelines is because there's a tendency to use those echocardiographic findings as a surrogate for an overall clinical decision, exactly in this case of a person who's a smoker and also probably does have some heart failure with preserved ejection fraction, to use that as a surrogate for the diagnosis of heart failure, which of course it's not. You have to use your clinical judgment in that case. So I think that these parameters are available for reference. I always encourage active discussion between people who order an echocardiogram and the cardiologist who's managing that patient, if there's one available or involved, to basically get through the weeds of what could be heart failure with preserved ejection fraction. So, and again, a clinical diagnosis. And if in doubt, put them on 20 of Lasix and see if it works. It literally comes down to as simple as that. Just try stuff, right? So, hey, if you guys have any, I certainly want to entertain any questions because that was pretty dense content. And again, the slides are available for reference. But so you know what can be seen and what cannot be seen on a transthoracic echocardiogram.